Good evening, everyone. Thank you for joining our Fireside Chat for this evening. We are going to have our Fireside Chat number 194 today. Professor Robert Kalyesubula is going to take us through. But before we start, I just want to introduce him with a brief bio. So Prof is a chair of Physiology at Makerere University College of Health Sciences. An adjunct clinical associated professor at Yale School of Medicine in the United States of America, and a consultant nephrologist at the Mulago National Referral Hospital. Prof. Kalyesubula has a Master's of Medicine from Makerere University and holds a nephrology fellowship from Yale University in the United States. He also has a PhD in non-communicable diseases from London School of Hygiene and Tropical Medicine, with over 18 years of experience working in the field of non-communicable diseases as an educator, clinician, and a researcher with over 140 peer-reviewed publications. He is also the founding president of the Uganda Kidney Foundation and the current chair of the education committee at AFRAN, African Association of Nephrology, and the executive board member of ISN. He recently also presented the future of African nephrology at 2030 at the AFRAN presentation. And maybe this is something that we can probably have another session with you, Prof. We can, for those of us who weren't able to come through to AFRAN, maybe it is something that we can have in another session. So Prof is going to take us through a very important topic, and I believe this is very important, not just for nephrologists, but for all our junior colleagues and other disciplines as well. It's on screening for chronic kidney disease and cardiovascular risk management for improved outcomes. So Prof, the mic is yours. Thank you so much.
Thank you very much, Dr. Makerere, for the wonderful introduction. Sometimes I don't believe I'm all of that, but anyway, thank you very much for the wonderful introduction. So today I'm going to be talking about a wonderful topic of screening CKD and cardiovascular risk management for improved outcomes. I want to thank the Africa Health Network for giving me this opportunity, and I want to apologize for having missed the previous presentation. They really were nice to me because we really had a tight program. I was going to give the talk at the airport, but doctor was very nice to postpone it to today. So I'm very grateful for that because I really wanted to give this talk because I prepared for about 2 months for it. So I'm going to be talking about the global causes of death, which most of you, as I hope, nephrologists and other practitioners know: hypertension, CKD. Then I'm going to talk a little about the cardiovascular kidney metabolic syndrome, which seems to be a very important part of what we should be doing as clinicians. And then I'll talk about management of this cardiovascular kidney metabolic disease. Then I'll share a few lessons from what we know in Uganda and what we are doing to bring this back home. So as we know, the leading causes of death are actually cardiovascular disease, occurring in 32%. But when you look at closely at the particular diseases, you find that kidney disease is about the 7th cause of death. So it is involved somewhere in the causes of death. And although kidney disease, as we know, is rarely diagnosed. Looking broadly at the bigger risk factors, in the world we have about 1.5 billion people living with hypertension, and that's defined as a blood pressure of 140/90. It gets higher as people try to define it for pre-hypertension. When it comes to Africa, we are looking at a prevalence between 20, and some countries have gone up to 49. And in Uganda, in some studies we've done in 2018, we've shown that the prevalence ranges from 22 to about 33 in the bigger towns. When it comes to diabetes, we are not spared either. About 537 million people are living with this disease, and this is projected to increase to about 643 million. And the majority of this is actually in sub-Saharan Africa, where we see it increasing up to about increasing by about 134%. And in our countries like Uganda, it is actually also still a very big problem. We've seen it rise from about 0.64 million people in 2014 to 1.5 million in 2023. And 50% of those individuals did not know that they had hypertension. And when there was a recent publication in Monitor is one of our leading newspapers, and they actually showed that the young people had obesity up to about 29%. And this has been rising over the last 10 years. And when you look at the world over, people who have a BMI of greater than 25, looking close over the years, this is really a growing epidemic. This is all data. I could not find data going to 2023, but really everyone appreciates that this is actually a really growing epidemic. And 1 in 8 adults actually have obesity. We are talking about a tsunami here. And when you go and you look at the burden of kidney disease, which is our area, we currently know that about 850 million people are living with the kidney disease, and a conservative estimate of about 13% in sub-Saharan Africa. But what is worrying is that up to 90% of these individuals living with kidney disease do not know that they have it. And look, when you see this 10% of the people who actually know that they have kidney disease, up to 80% of them are actually not on an SGLT2 inhibitor, and some are not managed by an expert. Very few are actually on the hypertensive medicines, especially SC inhibitors. So their management is really suboptimal, if we are to say. This is a slide I've shown you before, I think, for those who attend here, but it's a very important slide. We did this work in 2022. It really shows us that number one in this slide is that we have certain risk factors that are common to us as people of sub-Saharan Africa. For instance, we have genetics. The ApoLA1 gene is very well known to us. And then we have pregnancy-related complications. Eclampsia is very common in our people. And then they have all these abortions and all those things because our people have a high fertility rate. When you come to comorbidities, yes, hypertension, diabetes is there, but we have also infections, particularly HIV infection, which has been well studied. We have things like sickle cell disease, and then we have these other exposures like endemic infections. Malaria is very common, TB, leishmaniasis, talk about all these infections. Then we have nephrotoxins, like the snake bites, envenomations. But important here to note are the repeated episodes of AKI. And this model will show that when you have AKI, it can actually progress to acute kidney disease. We now have a definition of what happens between 7 and 90 days. And then after the 90 days, we go into the chronic kidney disease, which can actually lead to kidney failure, cardiovascular complications, and death. But the key to note here is that if we acted early enough, you can see those arrows moving back, the blue, the black going backwards, that we can actually reverse AKI if we discover kidney disease early enough. So this is a very important slide that I love because of the information it has to portray to all of us. And this is the heat map, which is again known to all of us. It looks at the classification of kidney disease. We have the glomerular filtration rate, which is staged from grade 1 to grade 5, and that is easy to know, and most of us appreciate that, depending on your percentage of kidney function. What we are less conversant, and many of us don't use very well, is the microalbuminuria, or the urine albumin to creatinine ratio. So here we have the microalbuminuria if less than 30 milligrams per gram, that is A1. Then you go through to A3 when it's greater than 300 milligrams per gram. Not that we use the milligrams per grams, but you could use millimoles. So here you can see, I'm going to take G3B, please. I don't have a pointer, and I don't think you can see, but if you look at the level of G3B, we look at the moderate to severe decreased kidney function. If these people have mild microalbuminuria, then they have actually moderate risk. But if they go ahead and they have moderate microalbuminuria, then they actually have severe risk, and they would actually need to be treated. They will need to be, if they have more than 300 milligrams per gram, they would actually need to be referred to a nephrologist for care. Remember that, of course, the proteinuria speaks to the structure of the kidney, and then the glomerular filtration rate more to the function. They have also looked at the different causes that goes into the glomerular, the glomerulonephritis, and all those other things. So this heat map is very important to know when to refer. You can see that even if someone has a normal GFR of greater than 90, but they have a proteinuria of 300, or the microalbuminuria of 300 milligrams per gram, you should actually refer them to a nephrologist, because these people have a very high risk, as I'm going to show you, of progressing to actually chronic kidney disease and even getting cardiovascular risk. We've done some work in Uganda, and we've shown that most people present late. In this graph, you can see this blue. The majority of patients, over 50% of our patients, presented in stage 5 kidney disease, which was really bad. And they actually had LVH already, which was a cardiovascular complication at that time, and they were young. We have done other studies looking at about 50,000 individuals in Uganda. Of course, infections are still high up there, but what is worrying, though infections are coming down, you can see the creep up of the non-communicable disease, and lo and behold, across all age groups, the non-communicable diseases are increasing, starting way early in the earlier years, and then you can clearly say that even the chronic kidney disease was among the top 7 causes of infection and actually death. When we looked at people on dialysis, it wasn't very different. Up to 67% already had cardiovascular risk. This was a study done by Dr. Kansime for her Masters of Medicine, and she clearly thought that these people on dialysis actually already have cardiovascular complications and abnormalities. Now I'm going to switch gears a little and take us into the cardiovascular kidney metabolic syndrome, which is actually not so new kid on the block, but really something that we need to embrace and understand better. So this risk begins very early in our lives, even before we see anything. So we've known that the lipids or the adipose tissue presents a very big problem when you have excess of it, especially we know where it gets deposited, particularly that one on the tummy, the abdominal, when your abdominal circumference is greater than 100 for a man and greater than 88 for a woman, you have trunk obesity. So this overweight and abdominal opacity leads to impaired glucose tolerance, and this is where all the problems begin. So that is the stage 1, usually subtle, you don't know, but once you begin to gain weight, it sets off a cascade, and then we have the stage 2, where you have increased metabolic risk. This is where we have the metabolic syndrome, dyslipidemia, hypertension, we have diabetes in there, and then when you have actually hypertriglyceridemia, and that is where you have the stage 2. You go to stage 3, which is really subclinical cardiovascular disease in the cardiovascular kidney metabolic syndrome. If you did an evaluation, you find that we have begun to get atherosclerotic cardiovascular disease, and you actually also have subclinical heart failure in that stage. And then after time, if these people are not identified early and treated, you go into the full-blown stage 4 cardiometabolic syndrome, and here you have ischemic heart disease, you have heart failure, you have peripheral artery disease, stroke, atrial fibrillation in the face of stage 4 kidney disease itself. So this is the cardiovascular kidney metabolic syndrome at the different stages. And it's important to appreciate that these things occur together, and so they share risk factors, and whenever you get a heart problem or diabetes, your risk increases. In these graphs, I tried to show this. They looked at about 19,000 individuals, This is an old study, but it tells us that the 10 risk of mortality if you have diabetes alone is 7.7. And the 10-year risk of dying is 11.5 if you have kidney disease. But once you combine these two entities, actually your risk of dying increases to 31%. In fact, it is said that once you have diabetes and kidney disease, your risk of dying it increases by 31%, but also if you have these two entities, you decrease your life expectancy, especially if you reach stage 4, you decrease your life expectancy by 16 years. So in these ones, I try to show where you have patients who have diabetes and those without diabetes and the prevalence of kidney disease. So kidney disease, of course, clearly increases in those who have diabetes, and then also the albuminuria and impaired GFR increases the risk of mortality. That's what those graphs are saying. But the key information is when you have both. When you look at GFR and the cardiovascular mortality, clearly, this is an old study. I picked it because of the information. These people looked at 1 million individuals in a multivariate analysis and followed them up for risk of death from cardiovascular events. They followed up for about 3 years. They were quite a young population, 52 years and 55 were women, but they clearly showed, and this is for the first time, that whenever your GFR goes down, or whenever you develop a higher stage of kidney disease, your mortality and the risk of dying increases by almost tenfold. Cardiovascular events increase from a risk of 2.1% to 36%. The risk of hospitalization and this antecedent costs increase by about from 13% if your kidney function is greater than 60 to the odds are now 144. This is really an humongous risk, and it is actually very well explained. But what about the cardiovascular risk on the kidney disease? When the moment your left ventricular ejection fraction decreases, your risk of progressing to stage 5 kidney disease actually increases so much also. And of course, here people have said that if your GFR is declining after the 4th decade, we expect your GFR to decrease by about 1 ml per minute per year. If you get the diabetes, that actually gets accelerated. But if you have cardiovascular risk and your heart gets involved, this increases to 2 to 3 mils per year, which is actually very high. So getting cardiovascular disease, especially with left ventricular ejection fraction reduction, increases your risk of developing kidney disease. And this is the pathophysiology. I try to put it together so that I don't lose so much time. I could have gone for each of them. But you can see again here the fat, the adipose tissue is the big issue. Of course, it causes deposition and causes liver disease, hepatic steatosis. I know the names have changed, but you have a deposition of fat, and then this actually leads to hypertension, dyslipidemia, and the metabolic syndrome, which again leads to diabetes, which also increase the risk of inflammation, oxidative stress, insulin resistance. You get the blood vessel heat, and this is where you end up getting glomerulosclerosis, tubular interstitial fibrosis, and you end up getting chronic kidney disease. These interplay and increase atherosclerosis, they increase cardiac remodeling and fibrosis in the myocardium, and again lead to cardiac dysfunction. At the same time, once the kidney gets injured, you stimulate the humoral system, which also causes further problems. Now I'm going to focus a bit more on the kidney. This is from the KDIGO, which many of you know. So we should know from the start that if we are managing a patient with kidney disease, lifestyle modification is very important. If they are smoking, you tell them to stop. You can see this is looking at the different stages. As early as grade 1, lifestyle is very important. Smoking cessation is good at all time. RAS inhibition, optimizing control of blood pressure, use of statins whenever necessary is a whole block. Of course, when you have optimizing glycemic control to targets, usually for kidney disease, those targets keep changing, use of SGLT2 inhibitors, GLP-1, managing metabolic acidosis using sodium bicarbonate, and of course, looking at the underlying cause and avoiding nephrotoxins. So this is the spectrum I'm now going to try to address. So a health diet is very well known to us. Practicing it is a different issue, but would prefer that you put vegetables and fruits for half of your plate. Then you can eat your starch or carbohydrate, and then protein. Always remember a glass of water. Men need about 3.7 liters of water a day, and women need about 2.5 liters of water a day, according to the American guidelines. Of course, it's important to reduce tobacco, weight, and reduce salt intake. I'm not going to talk about that. Many of you have seen this slide before, and sitting is the new smoking. You try to avoid taking alcohol, you try to avoid smoking, but you sit for a long time during the day, and this could give you an equivalent risk to smoking. So if you look at this in detail, you drive away from home, you sit in your car, then you go and you sit on your computer, again you drive at home. I don't know if you are in Nairobi or in Dar es Salaam, and then you land in that big jam which takes you 1 to 2 hours. Then you reach at home, instead of resting, even if you did some exercise, you are finishing up some work or helping kids to do work, or seated, or you watch TV. And this is an average of 8 hours a day. What this translates to is about 231 hours per month, and you can actually spend 116 days, a third of the year, just seated. And so you need to watch those, because you might say, oh, I do exercise, I don't smoke, I don't drink alcohol. Well, sitting is the new smoking, and this is what this slide is saying. So it's very important that we avoid sedentary lives. Exercise, you guys know very well, I'm not undermining it, but it's not the topic for today. I want to look a bit at the pillars, the 4 pillars of managing people who have diabetes and hypertension, and then kidney disease ultimately. So these people definitely need the pillar of renin-angiotensin receptor blockers. This, of course, help in decreasing hyperfiltration. They help resolve the pathophysiology we saw up there. They help, of course, they help in the hemodynamic perturbation. Then you have the SGLT2 inhibitors. I'm going to be talking about those. But importantly here, you also have some newer molecules, the finerenone, which are the mineralocorticoid receptor antagonists, which are more specific than the other potassium-sparing diuretics, the aldosterone antagonists. Of course, we are also increasingly seeing the GLP-1 agonists. They decrease weight, decrease oxidative stress. And so these are the 4 pillars that anyone who has diabetes and the kidney disease with hypertension should be on. I'll just take a minute and pause to let you take this in, because I'm going to now delve into the studies that support these pillars. Okay, so I'm sure you've seen that. So let's now delve into the science. So the mortality benefits of lowering the blood pressure are very well known. The SPRINT study was a very big study that looked at many individuals to see whether extensive lowering of blood pressure to below to target less than 140/80 compared to those who had less stringent control. Clearly, there was a benefit to those individuals, and several meta-analyses have actually demonstrated that the lower the blood pressure, the better. It doesn't matter how you get there. Sometimes you want SC inhibitors, obviously, if you have proteinuria of more than 1 gram, but if the pressure is not going down, we've seen people using methyl dopa, minoxidil, at least get that pressure down and to target. That will help a lot of things. There are several studies that have demonstrated the role of SCE inhibitors and ARBs. The Referral trial, these were very important trials, quite old, but the benefit of SCARBs in kidney failure is unquestionable, and you can see the trials, several trials showed that there was that benefit. A note here is that you should never combine SCE inhibitors and ARBs. They caused more death in the accomplished trial, and so you never combine them. They cause hyperkalemia and they were associated with death. So please, the key there is never to combine them. When you look at the heart and the cardiovascular risk, there are several meta-analyses that looked at the sacubitril valsartan, and these actually demonstrated that even in patients with end-stage kidney disease, this increased the hospitalization in these patients. The all-cause mortality was actually low, but it didn't reach statistical significance. The hyperkalemia was not so different because we always worry about that because of the valsartan. And then symptomatic hypotension was also a bit on the rise, but it was not statistically significant. But there was a good improvement in the left ventricular ejection fraction for these individuals. So sometimes we are asking ourselves, should we be putting these people on SEARBs? And if they have any heart problem, you can actually use this sacubitril valsartan, and it will do a good job, much better than sticking to an SE inhibitor. Now, if you look at the SGL2 inhibitors, these are drugs which are very wonderful. Now, they've actually replaced aspirin. You could actually almost give them to everyone. They really have no risk of hypoglycemia. They're associated with weight loss. They have benefits on heart failure. They reduce cardiovascular mortality, as I'm going to show you, and also improve renal function. So they have different mechanisms of action. They can actually act on the tuberoglomerular feedback restoration. They decrease oxidative stress and inflammation. They help to support the liver by reversing the effects of, I showed you, of steatosis. When they go to the brain, they actually have a compensatory increase in appetite. That is still questionable, but they are very protective to the kidneys and the heart, as well as the liver. They increase lipolysis and actually increase uptake of non-fatty acids. And when they go to the pancreas, they decrease insulin, but increase glucagon and also decrease glucotoxicity. So in essence, by doing that, they actually help to preserve the beta cell function. So they are very important. Although they don't lower the HbA1c very much, they do a very good job there. So the SGL2 inhibitors, I've just told you how they work. These drugs were actually first made to treat diabetes, but as you know, they showed very good effects at that time because of what had happened to the DPP-4 inhibitors, especially the thiazidinediones. Those ones actually increase the risk of cardiovascular death, and so FDA mandated all drugs to be tested for cardiovascular safety. And while they were doing this for the SGL2 inhibitors, they actually noted that people actually got better benefits far beyond just the lowering of the blood sugar. And you can see they act on the glucose transporters, they cause osmotic diuresis, and therefore decrease the interstitial pressure. They reduce oxygen consumption, reduce intraglomerular hypertension, and they have also indirect effects. Of course, these are very important, and they have been studied very well in different studies. And there have been a lot of studies that have been done to show the benefit of these drugs in the cardiovascular benefit, as well as in patients with or without diabetes. We have the double heart failure, we have the emperor reduced, and we have the double CKD, which showed benefits beyond doubt on people who actually had both diabetes and no diabetes. And you can see that in all these trials, these drugs actually have a benefit. They reduce the risk of dying, and they also reduce the cardiovascular risk the risk of cardiovascular disease, end-stage disease, and they sustain a GFR of greater than 50 in 39% of individuals, and they decrease the overall mortality, at least the dapagliflozin trial, which was published in New England Journal of Medicine, by 31%. And if you go and you look at the other drugs I talked about, finerenone is a drug, it's a mineralocorticoid receptor antagonist, which is very good. Of course, it's more specific than spironolactone or epinephrine. And in here, they looked at about 5,600 individuals in a phase 3 double-blind multi-center randomized controlled trial. And they followed them up for a composite outcome of kidney failure or a greater than 40% decrease in GFR over a 4-week period, or the risk of death from all cause. And they followed up these individuals for over 2.5 years. And then they noted that there was actually patients with CKD and type 2 diabetes, when they were treated with finerenone, the risk of CKD progression as well as the cardiovascular events were very much decreased in those who took finerenone. So it is now a drug of choice for those who have diabetes and kidney disease. Of course, the major problem with them is that sometimes they actually cause hyperkalemia. It's important to know how to start these drugs. So if someone has a serum potassium of less than 4 point, the major side effects is actually hyperkalemia here, because they are mineral receptor antagonists. So if someone has a potassium of less than 4.8, you can initiate them at 20 milligrams of finerenone. If it's about less than 4.8, but the baseline GFR is 25 to 59, you can reduce, you can consider starting at a decreased dose of about 10 milligrams. And then if their potassium is actually high, you maintain the finerenone dose so long as it's less than 5.5 millimoles. But the moment it goes above 5.5 millimoles, you have to withhold the finerenone. Of course, you shouldn't hold this forever. You take after about 72 hours, and you can initiate at a lower dose. So that's the administration of the finerenone. I'll be sharing some of these drugs. We have them in Uganda. The other drug is actually the GLP-1 agonist, semaglutide, which improved outcomes in type 2 diabetes and chronic kidney disease. In this study, they looked at individuals who had CKD and type 2 diabetes, and they started them on semaglutide, and they followed them out for about 2 years. Then they noted that in people with type 2 diabetes and chronic kidney disease, the drug significantly reduced the risk of kidney failure and cardiovascular events. And we are getting more information on the safety of this drug. Of course, I've seen some side effects come up, but this drug is so good. As you know, as scientists, you always aim for the benefit. So the number needed to treat to prevent the primary outcome of MACE was actually only 20 people. You treat 20 people to get a benefit of 1 person. And then if you looked at MACE, the number needed to treat is 45. And to prevent a cause of death due to any cause among those individuals who use this semaglutide over 3 years, the number needed to treat was only 39. These are very huge numbers when you look at trials. Some numbers, you remember in the times of COVID, if you saved 1 person after treating 1,000, then people thought that drug was working. Here, you only need to treat 20 to save 1. So that's how good these semaglutide drugs are. But what do they do? They actually act on different parts of the body. Remember, I showed you the axis of the heart, the kidney, and the pancreas together with the liver. So they also, this one now add on working at the brain to decrease the appetite, the increase satiety, people get full easily, and they also increase energy expenditure, which is very important in stopping the body from storing what it should store. Of course, it goes through all the CKM and actually helps to reverse most of those things which I shared with you earlier. So the pharmacological effects of GLP-1 agonists are very good on the heart and the kidney, as I shared earlier. So it's very important for us to appreciate. And these, they decrease the cardiovascular risk, the MACE, the myocardial ischemia, stroke, and the all-cause mortality. Of course, it's important to note that they decrease the HbA1c again by 1.5. They've seen weight reduction, decrease the blood pressure. Of course, they are not without a problem. Their major problem is usually GI intolerance. And of course, they are also People have used tablets, but I think in most of our settings, we have the injectable form. Their major problem is actually a reaction at the site of injection, but they cause a lot of nausea and vomiting. So the trick around that is to start small doses. There have been also a few cases of pancreatitis described. But if your patient has accelerated cardiovascular disease, if they are overweight, if they have a high risk of stroke, if they have diabetes, if they already have kidney disease and the SGLT2 is not working, these are perhaps the individuals that you might want to start this drug on. And these drugs, at least for Uganda, they are now available. We have semaglutide called Osema. Of course, we also have the real drug Ozempic, but it's still very expensive, but they bought this one also. Then all these drugs are now available in Uganda, even finerenone, even dapagliflozin in the different forms. I'm sure even our friends across East Africa and the other parts who are listening to us, we have all these drugs. So there is now no excuse for you not treating your patients very well. I hope I'm not rushing through too much. I'm now going to talk about some local experiences. This is the African Community Center for Social Sustainability. It's a community-based program based out of Nakaseke, which is about 61 kilometers away from town. And we wanted to integrate non-communicable screening using community health workers. Of course, this is the place I've talked about. We work in 3 sub-counties in Uganda, central Uganda. We engage the community through educating it. We have community health workers who support us. And in 2016 to 2019, we did a community survey where we asked people whether they had hypertension, diabetes. We found several prevalences. The hypertension was 19, diabetes was present in about 0.5, and kidney disease in 0.4. We went back in 2020 to 2023 and did a full community survey of about 3,000 individuals using trained community health workers. What we found that actually non-communicable diseases were common and there were no non-communicable disease clinics. So we established 3 non-communicable clinics to manage hypertension, diabetes, respiratory disease, and a bit of early CKD. We trained 20 community health workers and screened all those individuals. We used a pocket doctor, which is a very friendly book. This was interpreted in Luganda, which is our local language. And of course, people were shown and they were involved in forming these booklets, and they were really speaking to them simply and educating them. We work with Nakaseke Hospital, where we refer most of our patients, and they have a well-established HIV clinic and NCD clinic for managing patients with these chronic problems. So we train the community health workers. This is a picture of us. We also got some partners from the US to work with us. We train the health workers and then ultimately also train the community health workers. So for screening NCDs, we train community health workers to be able to use the WHO pen. This is the one that these guidelines were developed by WHO where you screen for risk factors. We also taught them how to measure blood pressure using an automated blood pressure machine, and then they would take weight and height. We are not able to do the waist-hip ratio, largely because we got feedback from the community and that was difficult. Some of our people were men and some people in the community did not want men taking the waists of their wives. So we really did height and weight, and then the measurement of blood sugar using a glucometer. And then we also taught them how to measure protein in urine using a urine dipstick. We trained them on tabs and how to transmit this data, and we recruited about 3,600 individuals. This is the community health worker screening for a dipstick to see if the patient had proteinuria. And of course, these individuals who were found with these problems were referred. What did we find? We found that about 4.7% of the community had kidney disease. This is only proteinuria, no GFR, and which is in line with what we found actually in a study which was done. Diabetes was a little low at 1.8, People say now it might be at around 3% in big towns, and this also was very significant. And then we found a lot of people with hypertension. But lo and behold, some of these individuals had these comorbidities, kidney disease and diabetes, kidney disease and hypertension. So there were a lot of people who actually had, up to about 0.2%, had multiple diseases, and that was a very big problem. So again, as a country, we've worked together with other colleagues to ensure that we develop some integrated guidelines to manage hypertension, diabetes, and kidney disease, working through AstraZeneca and Health Heart Africa and the Uganda Protestant Medical Bureau. So we've developed these guidelines. They clearly show charts of treating people with hypertension and CKD. I've shared this with you, but instead of just adopting what is available in the US, we've tried to look at the drugs which are available to us here. You can see we are using proteinuria because at the lower health facilities, they are not able to do urine albumin to creatinine ratio, but we have actually converted the urine albumin to creatinine ratio to the proteinuria, and we are able to actually pick up these individuals, although a few are missed. But this is the guideline. It is based on the proteinuria, and then you can go down. If they have proteinuria, you use ACE inhibitors. If not, you use other drugs to control the blood pressure. And then if it's not controlled, you keep going down. And when it comes to the diabetes and kidney disease, again, you can see these are the KDIGO guidelines. But again, here, we focus on our individuals. You can see the use of metformin, which is very good. You reduce the dose if the GFR is less than 45, and if it is less than 30, you discontinue metformin, and when they're on dialysis, you stop. You initiate SGLT2 inhibitors in anyone who has kidney disease, but if the GFR is less than 20, you do not initiate. You perhaps continue until the GFR is 15, or they go on dialysis. If they're on dialysis, we don't yet have enough evidence. But the key change here, if you are still with me, is we put here DPP4 inhibitors and insulin, as well as sulfonylureas and thiazolidinediones, ahead actually of the GLP-1 agonists because of cost. You find that the GLP-1 agonists are actually up here in the international guidelines, but because of cost and availability, at least as far as we are concerned, the GLP-1s are still a bit lower. But this is the guideline because we've adopted it to our setting. So that's very critical. We've also included a section on the comprehensive management and comprehensive care, which is now has actually a different name. It's actually comprehensive kidney management and conservative kidney care. So that one has to be part and parcel. It is now considered as the third arm of treatment. And for us, we talk about restricted conservative care, where you have restricted people don't have access to dialysis, either because they don't know that they have kidney disease, or they don't know that, or they don't really have access. We know that in Uganda, 90% of the individuals who need dialysis cannot afford it because it's very expensive. So in here, we focus on management of symptoms. Of course, we communicate and have patient at the center of the care. We use the multidisciplinary team of those individuals, and then also manage end-of-life care. And we also focus on management of symptoms, particularly urticaria, uremia, and all those things. All these things have been very well explained in our guidelines. We've also included a section on the management of CKD in women and children, because most of our kids also have sickle cell, they have CKD, they really have a lot of problems, and we've worked with the pediatricians, pediatric nephrologists to include this section. So this is how we are now translating the cardiovascular kidney metabolic syndrome into action. We've actually gone to the guidelines. They are soon going to be approved. So I know that I've talked too fast and too quick, but I think I've managed to convince you that hypertension, diabetes, and kidney disease are very common, and they are rising together with obesity, and hypertension, DM, and CKD are associated with a very high mortality. When they are together, this mortality can go up and reduce your lifespan by about 16 years. We've shared the risk factors and how we can prevent these conditions. And we have agreed that prevention is the key because treatment is very expensive. We have to integrate management in the best way possible because these factors are shared, and we now have very many new drugs we can use. We have talked about the 4 pillars as well as their evidence, but again, at the end of the day, all treatment should be individualized. And now we all have all these drugs in Uganda. I don't know about the other parts of Uganda, but I'm sure we'll be hearing from you whether they are available in Tanzania, Kenya, Rwanda, and Burundi, and other African countries. Then, of course, it's very important for us to screen. It's the only way, and it's possible. You can piggyback on the non-communicable diseases. Gone are the days when nephrologists used to be lone warriors, very brilliant, remaining in the nephron. Now the new normal is that you have to engage the cardiologist, you have to engage the diabetologist, you have to engage the endocrinologist to make sure that we work together. You have to engage the general physicians because now kidney disease is really a big problem, and maybe we made a mistake of making it so specialized. Everyone should have a role in managing kidney disease. And of course, we've also helped to develop the local guidelines, which I've shared with you. I just want to thank you again for having spent the last 40 minutes with me and listening to me, and for the organizers for giving me an opportunity to share today. I'm turning over to you, Dr. Amirai. Thank you.
Thank you very much, Prof. This was a very insightful presentation, and I believe that we had close to 90 participants online, and I believe that they have gained a lot from you. Especially experience coming from East Africa is very important because most of the time we hear experiences from other countries which may not be relatable, but Uganda is very close to us, and I believe that the challenges that you have is fairly similar to what we also have. I mean, for an example, you did mention that majority of your patients that come to you are actually already at end-stage kidney disease. That's the same thing we faced in our situation as well. Majority of the patients are already at stage 5, and these patients actually come in crash landing, and they need to be started on dialysis. And as we all know, dialysis is a very expensive, treatment, and not everybody, gets it. Similarly, to your side, only about 10% actually have access to dialysis of those who need dialysis. So it's imperative that we take this illness fairly seriously, given the fact that it doesn't have a lot of symptoms. And as you correctly showed, right, that the only way you can identify this is by doing screening, right? Identifying the comorbidities, getting the creatinine and the albuminuria, and only then can you realize that the patient actually has got CKD. So I think it is something that we all can learn from, and it's good to provide local context, especially what you did with your community. Picking up, patients with hypertension, and it was quite surprising to see that almost 30% of the cohort that you, screened had hypertension, which is scary because I mean that is close to almost half your population, and this, in all likelihood, may have been undiagnosed hypertension, right? And this I believe is everywhere, even in Tanzania. Patients come in and they have no idea they've got hypertension. So I think it's highly important that we make this a what do I say, a routine thing to do with any patient that comes into our clinics, right? Or education to maybe the rural areas where we have got doctors that are there. Maybe they're going to do their field work or they're going to do their clinical rotations, right? This is something that they should probably provide that information, because majority of people have no idea that these diseases exist, and then they end up with kidney disease. So I think it's very, 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 very relevant, and what you showed, I believe if we can replicate it in our countries, I think we should be able to at least make a bit of stride to try and slow down the progression of chronic kidney disease. I mean, we all know that we are facing an epidemic of diabetes, hypertension, and we know that chronic kidney disease is going to be one of the major causes of death come 2040, 2050. So I think if we are able to slow down, and it's a collective effort, it doesn't have to be nephrologists, as you correctly said, Prof. I think the members on this call, not many of them are nephrologists. Actually, majority of them are physicians and medical doctors that work, in clinics. So I think this is a very eye-opening talk that you've given. And on the medications that you have mentioned, I mean, it's very similar to our side as well. So the SGLT2 inhibitors, we have the generics that are available right now, and with regards to the other treatment as well, sulfonylureas, metformin is also available, but the GLP-1s are very expensive. Even the non-branded ones, the generic ones, are also quite expensive, and they're not registered as well. So it's very difficult to use those. But I believe that we are spoiled for choice, right? We have got multiple drugs that are actually working. There is no excuse why we shouldn't be using these drugs. So I think whatever is available at whatever setting that is available, I think it's important to use something rather than not using anything at all. And I think there are practical points that also need to be focused on, like as you mentioned about the hyperkalemia in the case of finerenone, but also with regards to hydration in patients with using SGLT2 inhibitors to make sure that they don't get dehydrated. And the other thing that is also very important is that if a patient is started on an ACE inhibitor or SGLT2 inhibitor, we expect a dip in their GFR. And this is something that people are very scared about. But this is something that we expect to see. And after a few weeks, it actually comes back up again. So if you do see the creatinine going down with the GFR, the creatinine going up and the GFR dropping, it's not something to be scared about, but rather to just persevere and see what happens. Because in the long run, this is beneficial rather than not using the drug at all. So thanks, Prof, for your talk. I will go ahead and start asking asking questions. Feel free to check the check box as well if you would like to. So we have a question from Dr. Tahani. Dr. Tahani is a nephrologist based in Dar es Salaam. And she's asking with regards to the use of eGFR for the diagnosis and a risk assessment tool in some CKD populations like older adults in pregnancy. I think it's about, can you use eGFR in older adults and in pregnancy as an assessment tool for CKD?
Thank you very much. Those are very important questions. So of course, kidney disease always increases with age. And as people grow older, they have less muscle mass. And of course, their creatinine is less. So creatinine is definitely not going to be a very good marker. There are certain formulas that have adjusted for eGFR in the older people. I don't know whether you have cystatin C, but actually, if you think that this person actually does not have the kidney disease and you have screened them, then you perhaps have to use cystatin C, and you actually use a combination of creatinine and cystatin C. In those older people, it might actually help you, although still you have to adjust for that age. That is very critical. Now, when it comes to pregnant women, because of their change in volume status and volume, and of course the cardiometabolic changes that occur in pregnancy, again, creatinine is not a very good marker of kidney function if you just measure it as a creatinine per se. So if you really want to take a test there, you need to do a less sensitive, but you have to do a 24-hour creatinine clearance. At least that's what is recommended. You have to correct the urine for 24 hours, and then you actually now calculate and estimate the GFR in those individuals. Because in pregnancy, you know that the creatinine goes down because of the dilution effect. So you would actually miss most of them who have kidney disease. So there you have to be very careful. You'll probably need to do a GFR measurement of some sort Of course, you wouldn't send them to a nuclide scan. So really
Yeah.
what you got there is 24-hour urine, which would be safe.
Yeah, and I think perhaps even if you have a previous creatinine range before they were pregnant, at least that will give you an idea also on what's going on. But yeah, point taken. It's important, Prof, as you mentioned. I mean, these drugs are available, and we just need to make sure that we should be prescribing them. But before we prescribe them, we should identify patients and screen them as you've been doing. And I think as a rule of thumb, any patient with any kind of non-communicable disease, namely hypertension and diabetes, whenever they come to your clinic, they shouldn't leave without getting screening tests done. Just a simple creatinine, just a simple dipstick protein, right? And counseling, right? I think that is the most important thing. That's the best treatment you can give, because you see what happens is the majority of the patients that would come to you, they would just come in and say, okay, I've come for a drug refill. And they would just take the drug refill and go, right? But I think this is something that we need to change. We need to say that, no, we need to check and we need to assess for complications and identify them early so that we can treat you earlier and don't end up with complications. That statistic that you shared about diabetes and CKD and the risk of mortality being 30%, that is very scary. I mean, a third of people that have that I think people don't know, majority of the people don't know this. And so I think it's important that we have these numbers right out there, to show people how bad these things are actually. Thank you very much, Prof, for your talk. If you don't mind sharing the slides with me, if anybody does ask for them, then I can share it with them. But yes, as I mentioned in the introduction, we would like to have a piece of that talk about the future of African nephrology. If you can come on sometime in the future, that would be very great. It would be something that
I think it was really a great talk.
Yes,
I learned a lot while I was preparing it, and we need to share it so that even the young people get interested in nephrology. There's so much opportunity in nephrology. I was just surprised myself. So whenever you have time, you will give me a schedule, and I would really love to talk about that.
Sure. Perfect. Thank you so much, Prof. This would be greatly appreciated. I will let you know. I would like to close this the webinar. Thank you, Prof, again for your insightful talk. It was very educational, and I believe that even though we didn't have a lot of questions, I believe that the message has been clearly sent through. Thank you, everyone, and I would like to wish you a good evening.